Hello and welcome to a new episode of Majlis podcast by Emirates Hospital Group. My name is 𝗠𝗷𝗶𝘀𝗀 and I'm a family medicine consultant at Emirates Specialty Hospital. Today is a great pleasure to have Dr. Zakariyya, a consultant gastroenterologist at Emirates Jumeirah. Dr. Zakariyya?
Thank you. It's my pleasure to be here. I am Dr. Zakariyya Al Mrayat, a consultant gastroenterologist and hepatologist. I've been practicing gastroenterology for about 20 years, and I've joined the Emirates Group recently. Over the last 3 months, I've been working in their Jumeirah branch.
Very welcome. Very happy to have you on board, and actually very happy to have you today's topic. I'm very interested in the topic of gastroenterology. So in today's episode, I'm hoping to ask you all the questions we want to know about gastroenterology. So small mission, but mission, I'm sure you're up for it. Do you mind me asking if we can start by, in your experience, in that 20 years of experience, what are the common presentations and the common groups of patients, if I may say, that you see?
Thank you. Well, in the clinic, most of our patients are actually acid reflux, or what people complain about is saying heartburn. It is very common. A lot of people have it. The second most common is probably the irritable bowel syndrome, or what is commonly referred to as IBS. And then we have the abdominal pain, where there is no specific causes found. Part of it is actually irritable bowel syndrome. And we have the inflammatory bowel disease, or the IBD, or what people generally, usually call ulcerative colitis and Crohn's disease.
Okay, fair enough. So there's overlap or maybe misconception whenever, because of maybe the name and the abbreviation IBS, IBD. And I guess because of the nature, I don't think any one of us never had some irritability in their colon. So sometimes we jump and we say, oh, I got IBS, whereas it's probably I just have irritable bowel. Now, again, from your experience, like the IBD, IBS division, are they same spectrum? Are they same disease? And how do I proceed if I have a bit of irritability in my colon?
Thank you for this question, because I've seen it in my clinic. Some people, they tend to tangle the two things together. They are completely two different diseases. One is what we call a functional disease, where there is no organic causes found. That is the irritable bowel syndrome, or IBS. And the second one is the inflammatory bowel disease, where you can see ulcers and inflammation inside the colon. And I've seen patients misdiagnosed as IBS after a 3-day history of abdominal pain, which you can't do. There is a specific definition for irritable bowel syndrome, and that is pain on at least 1 day of the week for at least 3 months, associated with change in the stool. That could be the number of times you go to the toilet, or the texture of the stool, or the consistency of the stool. So you have to have the pain for at least 3 months so that we can call it irritable bowel syndrome. And you shouldn't have any alarming symptoms with it, like, blood in your stool is definitely not irritable bowel syndrome. If you lose weight, it is not irritable bowel syndrome. If you're having poor appetite, it's not irritable bowel syndrome. If you have family history of certain diseases in the colon, that is not irritable bowel syndrome. So if I want to pass a message to the patients, is that make sure you have irritable bowel syndrome by seeing the right specialist, because sometimes they are diagnosed quickly in a clinic, or maybe by their neighbor. The neighbor tells them, oh, you have irritable bowel syndrome, which is not the case. I've seen so many cases where the patient has been suffering for 10, 15 years with symptoms in their tummy, pain, diarrhea, constipation, you name it. And they were diagnosed as irritable bowel syndrome, and in fact, they have something else which can be treated, completely cured.
And that's a very important message. Thank you. So basically, if I go over for a weekend break and I come back with abdominal pain, it's not irritable bowel syndrome. Definitely. It's more irritable bowel. And you mentioned the alarming signs, and that's it's an important point that I want to elaborate further now. So this is probably where it takes us more into what we say, like more kind of like proper disease, in the sense that non-functional and organic conditions, so yes, like the IBD. So what do I expect as a patient that I'm having symptoms, maybe 1 or 2 symptoms that are concerning? I've seen sometimes blood, I'm having a change in my bowel habits. I make an appointment, I see the gastroenterology. If you don't mind kind of walking me through the journey. What do I expect in terms of the diagnosis modality, and how do you proceed in your clinic?
Well, as you know, you're a doctor, and as most of our viewers know, that once you go to a doctor, you complain of certain symptoms. The doctor usually asks you a lot of questions, which we call the history. And after the history, we go on and examine the patient clinically. Very rarely we find signs, but they might help us. And then in today's medicine, we like to investigate. We don't like to leave any symptom uncovered. We don't like to just tell the patient, oh, it's nothing to worry about. We have to make sure. And we make sure we have a lot of tests. We can use them. We can make sure by blood test, by a stool test, by a camera, by a scan. There's so many things which we have just to make sure we're not missing anything serious, which if we catch early, we can treat, cure the patient from. But if we leave it late, we may not be able to cure it.
Absolutely. So early diagnosis is the key. And I do find from time to time some patients are afraid to see the gastroenterologist because they think that the minute they walk in, they will end up getting a camera test. So that's obviously not the case.
Oh, definitely not the case. We like to make sure that the patient actually needs the camera. It's an invasive procedure, and very rarely it has complications. Only probably when we are doing some kind of surgery inside. But it doesn't mean if you go to a gastroenterologist, you will get a camera. No, most of my patients actually do not get cameras done. It's just if I find something in the tests, if I find something in their history, which make me worry as a gastroenterologist that I might be missing something serious, I would certainly advise them to have the camera done.
Of course, and that absolutely makes sense. Thank you for clarifying that. Now, let's maybe challenge you a bit more about we live in a fast era of technology. Things are changing very quickly, and even for myself, keeping track with the technology. What's happening in the world of gastroenterology with artificial intelligence and machine learning in terms of diagnosis? Has it been different? I mean, are there new things happening at the moment?
Absolutely. Thank you for this question as well. We have actually used artificial intelligence in colonoscopy over the last 3, maybe 4 years. And one of the important research topics that actually came out of this country and from 𝗘𝗺𝗃 Medical Center by Professor Michael Wallace was 2 years back, when they did a study to look at colon polyps when they are doing a colonoscopy, whether with the use of AI you can pick up more polyps rather than without using the AI. And they found out that actually you are twice more likely to catch polyps using AI rather than without an AI. So in a lot of hospitals nowadays, there is an artificial intelligence system inside the colonoscopy, which will point, you see these red squares pointing to you where the polyp is in case you miss it. Now, most of the time, these polyps are actually because of what we call a suction mark. When we suck the mucosa, it shows as a polyp. But we have the discretion. But they point us to that. The second thing is that I've just been reading reports about a new drug for inflammatory bowel disease that was designed by AI because there is so much data which you can put it in a system. The machine will tell you that if you tweak this kind of drug to that kind of drug, you might get better response. What if I may, I am going to talk about inflammatory bowel disease here and the new medications that have started. We have the biologics. These are medicines which are made from living organisms, and we give them usually in the vein as infusions. In the past, maybe 20 years back, we started to have the first one, which is called infliximab. Now we have more than 10. And every time, the safety of the medicine becomes better. The response of the patients become better. So when we started with infliximab, maybe 20 to 30% of patients would respond. Nowadays, we're looking at, in some cases, 60% response rate. Oral medications, the response rate is actually gone even better, with sometimes quoting as 90%, although this needs to be confirmed. Now, I deviated a bit about the topic of AI, but I wanted to tell our audience that even if you don't respond to one kind of medicine, it is not the end of your journey. There are other medicines which you can use. There are so many medicines in the pipeline. I am sure one of them will, with the use of AI, will help you in controlling your symptoms.
This is very amazing. And again, I'm learning as usual from my guests. And the oral medications probably going to take over from the IV, which means it's easier for patients in terms of time and compliance and all of that.
Absolutely. There are new studies on the oral medications which show a very high response rate. Now, we don't go straight to them because we don't want, to use our last defense against this, if you like. We like to go with the ones that we've used so far. We know what their side effects are. We know what to expect. Now, you mentioned AI. Now, AI now is being used as well for all this data to help us predict what is going to happen. In fact, in some places, they are using AI in pre-disease. They put the data of the patient because some abnormalities happen before you actually get the symptoms. And they put this information into these supercomputers. And they tell you that this patient is likely to have this kind of disease. This patient is likely to have a stormy course. This patient, this medicine will not work for. So the AI can predict for you what is going to happen. In fact, maybe 12 years back, I was in a conference in Europe, and one of the researchers tried to tell us that we are trying to predict what is going to happen, and they published a paper which showed that some patients who have inflammatory bowel disease and they need to use a lot of steroids, these are medicines with a lot of side effects, and we don't like to use them unless it's absolutely necessary. They are likely to have a stormy course. So the initial way of predicting what is going to happen in inflammatory bowel disease started a long time ago, but with the use of computers, they're speeding things up. So I expect maybe in the future, we're going to have an app where the patient enters the symptoms, enter what happens with him on an hourly or a daily basis, and we would be able to tell, oh, this patient, this medicine is not going to work for. We might as well use this medicine.
That's very fascinating. Are we at risk of losing our jobs? Will my employer find a new machine and to replace me?
Well, I am old, so I don't think I'm going to lose my job. Maybe in your case, you have to be worried.
Well, thank you for calling me young, but I'm hiding the age. Now, and again, thank you for this summary. I know it's a very complex topic, and you're doing your best to keep it simple for our audience.
Right.
And you covered the new treatments, and you covered that for every patient, there would be an option. So it's not, if I'm on infliximab, another patient who has similar diagnosis might be on the same treatment. And that's very important because we have to take every patient's needs and symptoms into consideration.
Exactly. That's what AI is trying to do.
Looking forward for the future, right?
Yes, absolutely.
Now, I'm going to challenge you a bit. And I admit, I don't know much about it, so I'm very intrigued to know what you hear people talking about the FMT, the fecal microbiota transplantation. And I admit, I honestly haven't heard of it before. I don't know patients or doctors who've been using it. What can you tell us more about it?
Well, fecal microbiota transplantation is actually you take microbiota or a fecal matter from a normal person and you transplant it into a patient who is diseased, like somebody with inflammatory bowel disease, somebody with a Clostridium difficile infection. We have tried this in the past and it works magic for a Clostridium difficile. But with inflammatory bowel disease, it has been tried, and the reviews and the papers on it have been contradicting. Some have said that it works, and especially in Crohn's, more than in ulcerative colitis. And some have said that it doesn't work. And some studies have said that the way you deliver this bacteria to the gut of the recipient, it works if you deliver it through the mouth. It doesn't work if you deliver it through the colonoscopy. So it's too early to say whether it works very well in inflammatory bowel disease. It is not to be recommended because all the guidelines, and the stakeholders who usually put these guidelines have not recommended its use in inflammatory bowel disease. It is recommended in Clostridium difficile, which is a bad infection, which some people in inflammatory bowel disease get, but that's a different issue.
Fair enough. It's not a very appealing thought, but to get this transplantation done. But yes, I could see why it could work for C. diff because of the bacteria. Yeah. But whereas the IBD is more autoimmune, so it could be a bit more complicated.
Well, there is nowadays there is a talk about the gut-brain axis and the microbiota and how they influence the development of inflammatory bowel disease. So maybe microbiota has a role to play in inflammatory bowel disease. Maybe if we transplant normal microbiota, and we don't know what the normal yet, because there are at least so far 2,000 kinds of microbiota inside us. Now, these the kinds. Now, the numbers are in trillions. So we don't know so much about microbiota yet. How much do we need to give the patient? For how long? We don't really know as yet. Now that's when AI comes in, and you sort of get the whole picture, where there is the mix of the causes of inflammatory bowel disease, the microbiota, the AI, all coming together to help us untangle this huge puzzle, which it would be great for the patients if we can untangle it.
Which is another thing to look forward to see how things are going to progress with the FMT and the AI as well. Now, another challenge for you today, and I'm sorry to keep pushing you, but I'm just enjoying the talk. So, stem cell, where are we in terms of stem cell? Because again, it's a big topic. We hear a lot about it in different aspects in medicine. Where is IBD, gastroenterology, and stem cell?
Okay. There was a lot of media talk about stem cell maybe a few years back, when somebody in Nottingham tried to use stem cell for Crohn's disease with excellent results, apparently initially. And stem cells are cells which are the building blocks of the body. They can differentiate, you start them, they are young cells. If you give them if you transplant them into a patient, they change, into a skin or a collagen or a hematopoietic cell. So they are the building blocks, if you like. There are two kinds, the hematopoietic ones and the mesenchymal one. The hematopoietic one is actually you introduce them to the body, and they replace your bone marrow, which is making, your white blood cells, your red blood cells. Now, we know in inflammatory bowel disease that the problem, at least partly, is because of your immunity is not right. Your white blood cells, which defend your body from outside effectors, they attack the lining of your gut instead of attacking the allergen, if you like. So we don't know why the white cells do that, especially T cells. So what happens is, if we get rid of this lineage of white blood cells and put new ones, then the new ones should be all right and should not attack the body. So this is the hematopoietic. The problem with that is that you have to kill off all the white blood cells that you already have and introduce them. So there is a risk of infection there. The other thing which might happen is that if you introduce these hematopoietic cells, your body might reject them. And you get graft versus host disease. Now, with the mesenchymal cells, these can change into collagen. Apparently, there has been a success with them in treating anal fistulas in Crohn's disease. These are a very annoying sort of condition, which happens in about 20% of patients who have Crohn's disease, where they get this extra tube around the anus and it discharges pus. So we need them closed. So what they've been trying to do is to inject these stem cells into these tracts, if you like, and to block them. There is also some studies which we have not had in practice yet, where one of the complications of ulcerative colitis and Crohn's disease is narrowing of the gut, because they become fibrous with time. Continuous inflammation causes fibrosis. They inject these stem cells into these strictures and see if that is going to relieve the stricture. Now, with the injections into the fistulae, you get sort of local complications where there is extra pus coming from that area, but that's usually goes away with time. But it has not, it is not in practice yet. It is in specialized centers, centers which see a lot of patients with inflammatory bowel disease, yes. But in your, town hospital, this has not been seen yet.
Thank you. I think it's a difficult question and they summarize it very well. And I must say, in my 18 years of practice as well, things have changed so quickly and so fast, but I'm very happy to hear how promising the future is. And gastroenterology in particular is evolving very quickly with all what we mentioned today's episode. Now, again, I can keep you here forever and talk about every topic in gastroenterology because it's a very wide range, digestive diseases and all of that. But if I may conclude today, any last message you would like the audience or today's audience to know about?
Yes, my message to irritable bowel syndrome patients: not every pain you have in your tummy is irritable bowel. Irritable bowel can be confused and mistaken for other diseases. I can give you examples. I've had patients who have pancreatic insufficiency who were treated as irritable bowel syndrome, but once we discover that they have pancreatic insufficiency and they give them the medicine, their symptoms eased. I have more than 10 patients who were diagnosed as irritable bowel syndrome when in fact they have celiac disease or gluten. I have more than 50 patients who were diagnosed as irritable bowel syndrome when their problem was actually lactose intolerance. I have few patients who've been diagnosed as irritable bowel syndrome when in fact they have inflammatory bowel disease. So not every patient who has pain in their tummy is irritable bowel syndrome, and not every irritable bowel syndrome is actually irritable bowel syndrome, if you see what I mean. So get investigated and see a proper doctor. When I say a proper doctor, I mean a gastroenterologist to investigate you further to look for a cause of your tummy symptoms.
Thank you very much, Dr. Zakariyya, for being our host and for all this valuable information. This concludes today's session of Al Majlis podcast by Emirates Hospital Group. Stay tuned for our next episode soon.
Thank you for having me.
Pleasure.